Hello everyone, I'm Anas Al-Ubaidi, and the topic or the title for this lecture or session is Documentation of Common GI, Gastrointestinal and Nephrology Scenarios. It is with Chapter 30 about the review of gastroenterology and nephrology scribing within the Certified Medical Administrative Assistant Course Program by ACMSO. Introduction. In the realm of healthcare, precise and comprehensive documentation is paramount, especially in specialties like GI, gastroenterology, and nephrology. These fields often deal with complex and chronic conditions that require meticulous record keeping to ensure continuity of care, accurate diagnosis, and effective treatment planning. This lecture aims to equip advanced medical scribe students with the necessary skills and knowledge to document common scenarios encountered in GI, gastrointestinal, or gastroenterology and nephrology settings. By understanding the nuances of these specialties, scribes can significantly enhance the efficiency and quality of patient care. Gastroenterology focuses on the digestive system and its disorders, encompassing conditions such as IBS, irritable bowel syndrome, Crohn's disease CD for short, and liver cirrhosis. Nephrology, on the other hand, deals with kidney function and diseases, including chronic kidney disease, acute kidney injury, and electrolyte imbalances. Both fields require detailed documentation to capture the patient's history, symptoms, diagnostic tests, treatment plans, and follow-up care. Key points: gastroenterology documentation. Patient history and symptoms. Capturing a patient's history accurately is crucial for effective documentation in gastroenterology. This step includes detailing medical history, record any past diagnoses such as GERD, gastroesophageal reflux disease, IBS, irritable bowel syndrome, or peptic ulcers. Include surgeries like appendectomy or past GI tract resections. Family history. Document hereditary GI disorders such as celiac disease, CD for short also, or colorectal cancer. Lifestyle factors include dietary habits, for example, high-fat foods, spicy meals, alcohol consumption, smoking history, physical activity, and stress levels. And here is a diagram on patient history components. Symptoms, not the chief complaint and its characteristics. Abdominal pain, location, severity, pattern, triggers like food or stress, diarrhea or constipation, frequency, duration, severity with associated symptoms like blood or mucus in the stool, nausea, vomiting, bloating, and food intolerances. Special considerations for patients with chronic conditions. Note how their symptoms fluctuate over time. Include travel history or recent use of antibiotics, which may suggest infections like C. Or Clostridium difficile. Accurate inclusion of this information provides the foundation for evaluating and diagnosing GI conditions. Example: a patient presents with abdominal pain after eating fatty foods. Their history reveals a high-fat diet and a sedentary lifestyle. Symptoms including bloating and nausea suggest possible gallbladder issues such as biliary colic. Diagnostic tests and procedures. Documenting diagnostic tools used in GI, gastrointestinal, or gastroenterology is vital for correlating clinical findings with potential conditions. Common tests: we have endoscopy, record indications, for example, suspected peptic ulcer, type of scope used, findings, for example, erosion, ulceration, and complications. Then we have colonoscopy. Note bowel preparation adequacy, any polyps found, location, size, and any tissue samples taken for biopsy. Imaging CT scans for assessing inflammation, such as pancreatitis. MRIs for detailed visualization of the biliary system or staging cancer. Lab or laboratory tests include any GI specific lab values such as liver function tests, including ALT, AST, bilirubin, stool samples for blood or infections, and Helicobacter pylori screenings. H for short, for Helicobacter pylori screenings. Clinical applications summarize findings in the context of symptoms. Uh, Positive detection of Barrett's esophagus in an endoscopy should correlate with the history of GERD, gastroesophageal reflux disease, and symptoms of acid reflux. Example, for a patient with chronic diarrhea, a colonoscopy reveals mucosal inflammation suggestive of UC, which is short for ulcerative colitis. Of course, ulcerative colitis, it is one kind from two of inflammatory bowel disease, as the other inflammatory bowel disease other than the ulcerative colitis is um, um, Crohn's disease, CD. Now, for this example, for a patient with chronic diarrhea, colonoscopy reveals mucosal inflammation suggestive of ulcerative colitis. Treatment plans and medications. Treatment plans for GI scenarios require clear and specific documentation covering medications. PPIs for short, which is short for proton pump inhibitors for GERD, immunosuppressants or biologic agents for Crohn's disease, CD, antibiotics for infections like H. pylori, Helicobacter pylori, antidiarrheals or laxatives depending on the condition. Now, non-pharmacological treatments, detailed dietary instructions such as a lactose-free and gluten-free diet for intolerances, lifestyle changes including smoking cessation and stress management. Surgical interventions, indications for procedures like laparoscopic cholecystectomy for gallstones should be included. Chronic care adjustments integrate long-term treatments such as fiber supplementation or preventive screening colonoscopies for colorectal cancer. Importance here, accurate documentation ensures medication adherence and feasibility of long-term care plans, particularly for chronic conditions prone to exacerbations. Example, a patient with Crohn's disease is CD, which is the other kind of inflammatory bowel disease, is prescribed with adalimumab and the brand name Humira for it, along with a low residue diet to reduce symptomatic flare-ups. Follow-up and monitoring. Regular follow-up and monitoring are critical for tracking the progress and effectiveness of GI gastrointestinal treatments or gastroenterology treatments. Scheduled visits document future visits for review of labs or imaging results and adjustments in treatment as needed, monitoring progress, not improvement or worsening of symptoms, and any side effects from treatments. Specify any labs required for monitoring, such as liver enzyme levels in patients on biologics. Screening protocols for conditions such as Barrett's esophagus include recommendations for surveillance endoscopy every 2 to 5 years. Supporting continuity of care. Summarize key findings and updates so future encounters build on current information. Example, patient with GERD started on omeprazole, which is a proton pump inhibitor PPI, returns for follow-up. Improvement in symptoms is noted and a repeat endoscopy is scheduled in 6 months. And here is a diagram showing the GI treatment follow-up cycle. Nephrology documentation, renal function and symptoms. Documenting renal symptoms and kidney function requires focus on symptoms, fluid overload symptoms like swelling in the legs or eyelids, uremic symptoms like nausea, fatigue, confusion, or metallic taste, changes in urination frequency, pain, color, or amount. Lab results include key lab findings, glomerular filtration rate, GFR, measure of kidney function, creatinine levels, and BUN, which is a blood-urine nitrogen, electrolyte disturbances like hyperkalemia, hypocalcemia. Patient risk factors: hypertension, diabetes, cardiovascular diseases, or history of recurrent UTIs. Document potential nephrotoxic medication use, for example, non-steroidal anti-inflammatory drugs, for short NSAIDs. Example: a hypertensive patient presents with progressive leg swelling and reduced urine output. Labs reveal elevated creatinine and potassium levels, including kidney or renal dysfunction. Diagnostic and monitoring tests. Effective documentation involves diagnostic tests. Urine analysis for proteinuria or hematuria. Document findings such as infection, nitrites, leukocytes, or nephrotic syndrome, foamy urine. Renal imaging, renal ultrasounds, or kidney ultrasounds help identify structural abnormalities. Renal biopsy for suspected autoimmune or atypical diseases include biopsy findings supporting diagnoses like glomerulonephritis. Monitoring chronic conditions. Record trends in lab values over time to detect complications like progression toward end-stage renal disease, ESRD for short. Example: a patient undergoing screening for kidney disease due to poorly controlled diabetes has microalbuminuria detected in a urine analysis. Treatment and medication management. Treatment complexities in nephrology require detailed documentation of pharmacotherapy, antihypertensives, for example, ACE inhibitors, ARBs, ARBs, to manage blood pressure and decrease proteinuria. Phosphate binders or calcitriol for managing secondary hyperparathyroidism in chronic kidney disease and CKD. Non-pharmacological approaches document prescribed renal diets low in potassium, sodium, and phosphate to minimize kidney workload. Record fluid restriction guidelines for patients with reduced renal output. Chronic disease planning include future planning discussions like preparation for dialysis or evaluation for kidney transplantation. Importance here: proper documentation ensures continuity when transitioning care from outpatient nephrology to inpatient facilities for acute complications. Example: a patient with electrolyte derangements due to chronic kidney disease (CKD) is initiated on dialysis. Prescriptions include loop diuretics and erythropoietin (EPO) for anemia. Dialysis and transplantation. Accurate records are vital for management during dialysis or post-transplantation. Dialysis here: hemodialysis schedule, access site, AV fistula, graft, central catheter, and any complication, for example, thrombosis or infection. Perform thorough documentation of fluid removal, trends, and symptom improvement post-session. Transplants, date of transplantation, immunosuppressant regimen, and current kidney function tests, creatinine, GFR. Monitor for signs of rejection or infection such as fever or decreased urine output. Critical insight here: document anticipated follow-ups such as renal ultrasounds at intervals post-transplant to ensure graft viability and patient compliance. Example: a kidney transplant patient undergoing prednisone tapering requires close observation for potential complications like hypertension or infection. Next, we have the summary tables. Here we have table of common GI conditions and symptoms, table on common nephrology conditions and symptoms, table on GI diagnostic tests and procedures, table on nephrology diagnostic and monitoring tests, table on treatment and medication management, and then next we will revise what we have covered through this lecture via some MCQs or multiple choice questions. Question 1. Which of the following symptoms is most commonly associated with irritable bowel syndrome (IBS)? Is it A, jaundice, B, abdominal pain, C, hematuria, or D, edema? So definitely it's B, abdominal pain, as abdominal pain is a hallmark symptom of IBS, often accompanied by bloating and changes in bowel habits. Jaundice is related to liver issues, hematuria to urinary problems, and edema to fluid retention. Question 2. What is the primary purpose of a colonoscopy in GI diagnostics? A. Measure acid levels in the stomach. B. Visualize the colon and rectum. C. Assess kidney function. Or D. Detect electrolyte imbalances. So it is B. Visualize the colon and rectum. as a colonoscopy is used to examine the interior of the colon and rectum for abnormalities such as polyps or cancer. It is not used for stomach acid measurement, kidney function assessment, or electrolyte detection. Question 3. Which test is most commonly used to assess baseline kidney function? Is it A, endoscopy, B, serum creatinine, C, liver function test, or D, pH testing? It is B, serum creatinine. As serum creatinine is a key indicator of kidney function, helping to assess how well the kidneys are filtering waste from the blood. Endoscopy and pH testing are related to GI issues, while liver function tests assess liver health. Question 4. In managing chronic kidney disease, which dietary modification is often recommended? A. High sodium diet, B. Low potassium diet, C. High protein diet, or D. Low calcium diet. It is low potassium diet, B, as a low potassium diet is often recommended for patients with chronic kidney disease CKD to prevent hyperkalemia, a condition where potassium levels in the blood become too high, above the normal maximum range. High sodium and high protein diets are generally avoided. Question 5. What is a common complication associated with hemodialysis? Is it A, claustrophobia, B, radiation exposure, C, infection at the access site, or D, perforation of the colon? So it is C, infection at the access site. So infection at the access site is a common complication of hemodialysis, as the procedure involves repeated access to the bloodstream. Claustrophobia is associated with MRI, radiation exposure with CT scans, and colon perforation with colonoscopy. And here we come to the end of this lecture. Thank you very much and goodbye.